So, Dr. Owens, thanks for joining us on our podcast today. Dr. Owens is going to cover, Dr. Owens has a lot of areas of expertise, but today we are going to cover and narrow it down a bit to ACL. So, we've got a few questions. Obviously, ACL is a pretty broad topic, so we're going to narrow it down just a bit to discuss a few of our newer trends and emerging options in ACL surgery. So, Dr. Owens, you have a pretty long list of career accomplishments. I'm sure you are our inaugural guest on this. I'm sure this is right up there with like co-editor of AJSM and that kind of thing, right? Being the inaugural guest here. It's like 1 and 1A.
It's pretty
Yeah.
inaugural guest.
Yeah, I know. Yeah.
No, it's an honor to be here. It's great to talk shop with you, and just excited. I mean, yeah, we could talk ACL for hours. I'm sure, but we'll try to keep it brief so we don't bore people.
Yeah. All right. Thanks. So, Dr. Owens, your philosophy, we have some surgeons that we deal with that start some of our ACL reconstructions on day 2 or day 3 post-op. You have a little bit of a different philosophy when it comes to those. So I was hoping you could maybe outline some of your concepts with delaying some of the start to rehab a little bit for some of your patients post-operatively, and kind of the concept of just allowing knee homeostasis to be restored following surgery. You can kind of shed a little light on your philosophy.
Yeah, I mean, I think it's interesting. I mean, we have certainly a lot of surgeons here doing ACLs, and I think it's fun to see different approaches. I think we do use a consistent protocol. I think we are always, some of us have a little bit concerns about motion, for example, or infection, etc. I think I tend to have a lot of patients that want to start rehab the next day. And certainly that works out really well for some of my professional or D1 athletes. They're a little bit different animals. They've got access to certainly advanced techniques and modalities, and certainly from a motivation standpoint and a time frame standpoint, they really want to get back as soon as possible. But not every patient really has as much to gain early on. Oftentimes after, especially an autograft, such as like a patellar tendon autograft, there's a lot of trauma to the knee. The knee is very inflamed, angry afterwards. And, it really can use a little bit of time to settle down. We make sure all our patients are in there with an appointment by 2 weeks, but certainly in the first week, I find that sometimes those appointments aren't as valuable as they are later on. Also, unfortunately, some insurances only cover a limited number of appointments. And I've had a bunch of people not blow through the appointments, but they're using them, 3 times that first week, 3 times the second week, and they only have X number of appointments. And then when things really start getting fun, right? It's like 3 months, they're on the treadmill, they want to run. All of a sudden their insurance says we're out of it. Or even make it to 3 months, right? They're at 8 weeks and they really need therapy, and their insurance is cutting them off and they don't have the means to pay cash for it. So that's the part I say, hey, look, the first couple of weeks, let's let the knee settle, right? And I don't think much is lost there. And then we begin moving it. In patellar tendon autograft, again, across the flexion crease, and really try to minimize too much early deep flexion, let that wound heal in.
Yeah, I think that makes perfect sense. And I mean, certainly speaking anecdotally, I've had more than my share of patients that I've seen day or 2, day 3 post-op that are nauseous on the table, or we got the trash can next to them, or they're sweaty, diaphoretic and ready to pass out. So yeah, I think you're right in terms of economically using this.
We try to give them a couple of basic things they can do there. So really the first things I worry about for that first 2-week post-op visit, where we take the stitches out and assess the wounds, I want them to have extension. That's the thing I can't ever really get back if you lose it early on, right? Maintain extension and get the quad to fire. And if you can do those straight leg raise and maintain extension, I'm pretty happy, right? Because usually we'll get the flexion back. We'll get everything else back. As long as you can kind of begin those early exercises, I think you're not missing too much.
Okay. Question for you. We've seen, especially recently here, there's this trend towards increased use of quad tendon grafts. I have my own personal thoughts, the pros and cons. I mean, so far, personally, I'm a little underwhelmed what I see from a rehab standpoint, but I just wanted to get your thoughts on kind of what maybe led to this push towards the use of more of quad tendon grafts, and then getting some of your insight from a surgical standpoint.
Yeah, I mean, so quad as a graft has been around for a while. I know personally, I've used it for around 15 years, way before it became kind of in vogue or the flavor of the month. I mean, certainly, I do a high volume of ACLs, a high volume of ACL revisions, unfortunately, and you end up having to use all the grafts. So some surgeons have one hammer and that's all they do, and we have to be available to harvest grafts from all the sites of that knee, contralateral knee, all these different options. And so I've been using the quad as a graft, and I think it's a very good graft. I think there have been some studies comparing sort of the geometry of the graft that really turned a lot of people on. Like, oh, it's thicker than the other grafts, and biomechanically it works well in an MTS machine that you put in a clamp and pull it apart. But that's not reality. One of the challenges is the fixation concepts. You still have a soft tissue graft that needs to be fixed to the bone, right? And so you use a button and you're relying on sutures, similar to the issues you have with hamstring graft. I think one of the reasons for the popularity is that, and most people that have shifted have been soft tissue surgeons. So those that previously employed hamstring grafts have switched to quad because they find that it's a thicker and more reliable graft. Also, in the past 10 years, there's been a lot of criticism of smaller hamstring grafts. So if it's not big enough, you have to go and add an allograft to it or something. And so now I got this nice, reliable, thick graft. The morbidity seems acceptable, right? And they don't get the hamstring weakness afterwards. We're going to use this graft all the time. So I think if the hamstring grafts were actually more popular worldwide because they're easy to do, and especially if you don't do a lot of ACLs, it was a less fear-inducing graft to harvest than a patellar tendon graft, where can have issues if you're not good at doing it. So I think a lot of people switched. But as I try to tell my patients, I do all the grafts, right? But I have 40 years of data on patellar tendon grafts, and I have around 5 years of data on the quad grafts. Really, maybe a little bit more with some series like John Sirajni's and Emory. Those have been doing it at high volume for a while, and they do well. But even just 2 months ago, a paper came out talking about the quad weakness we see after quad grafts. And so, as we get more comfortable with this graft, we'll begin to see more of the complications with it. And the first couple papers are like, it's the greatest graft ever. We've never had any issues. And it's like, well, really? Right? I mean, I think you're going to see quad weakness. You're going to see, all of the autografts have a downside.
Sure.
And
there's no perfect graft.
There's no perfect graft. And I think it's a matter of, not being one size fits all, and try to be customized the graft and the fixation for the needs of the patient. Right? There are some people that need everything you can throw at them, and some people that are maybe less demanding of their ACL. Someone like me, an older guy that is not constantly stressing his graft like a Division I soccer player or something like that. So I think quad is a good graft, right? But I don't think it's the only graft that's out there. And I do it especially for people that request it.
Well, that's what I was going to ask. If you have people coming in, I've done my research. I want the quad. Yeah,
of course. Sure. Ask them why, and it's always fun to talk shop a little bit. And unless they're making a wrong decision, and I really feel strongly against it, I usually go with it. I'd use that graft. They do well. I have no problem using that graft. I use a bunch of grafts. It's just a matter of sometimes informing them on the data. And I want my patients to be informed, but it's important to figure out where they're getting their information from. And there are a lot of sources of information, some of which are reputable and some of which are not. And I think it's good to at least have a discussion about that.
So in terms of kind of determining your ideal candidate, patellar tendon graft versus quad tendon graft, like who do you feel like fits into what category? How do you parse that out as far as kind of nudging somebody towards one graft?
Yeah, as it stands right now, I would say that the gold standard for the highest level athlete is a patellar tendon graft, and that has not changed. And there are certainly some individuals that use all quad for that individual, but in my practice, I haven't found anything to be superior as far as failure, return to play than a patellar tendon graft. There are some individuals that used to be relative contraindications to a patellar tendon graft, such as having a really long patellar alta, a long tendon, maybe an Osgood ossicle, patellar tendinopathy. I've used those grafts in the past and not had any problems with it. But some people maybe feel less comfortable with that and say this is a good graft to do a quad on.
Yeah.
There's some individuals that will revision situation, they want to use a quad.
Sure.
It's great in the pediatric patients that traditionally have small hamstring grafts, or in the past you haven't wanted to use any bone plug because you're dealing with an open physis. That's a great patient for a quad, right? And I think a quad is a really good graft, and it's just a matter of being thoughtful, about the approach. The people that usually want a quad are, I've actually had two therapists in the past couple of years that have come in requesting a quad, and I've given them a quad. Yeah, they do fine. The truth is, that all these grafts work very well. You need usually thousands of patients to find a difference. That's why you need these registries that we have, a few in the US, a few overseas, that really help provide quality data um, about the outcomes of these surgeries. It's more than just the graft, right? Because you can
Multifactorial.
Yeah, multifactorial. And a lot of surgeons, well, I use this graft, therefore it's the best. Well, not necessarily, right? It's where do you put the graft? How do you fix the graft? How are you tensioning the graft? How are you doing all your surgery, right? And that's just the technical aspects of the carpentry. Never mind the therapy afterwards and how and what the patient does. As I tell my patients, I get an hour with you, you get 6 months, right? And so that has a huge impact on how the patient eventually does.
So maybe let's tap into that a little bit. As far as technical challenges for our listeners who may not be as familiar with kind of the surgical mechanics of it, what are the differences harvesting quad tendon versus patellar tendon? And then I guess since you touched on it a little bit, what do you see long-term wise outcome in terms of what are the drawbacks of the quad graft?
Sure. So the patellar tendon graft is usually harvested with a longitudinal incision, meaning an incision along the length of your leg, right? So it usually goes right over the patellar tendon, and it has you can take a little bone plug from the kneecap, a bone plug from the tibia, and you kind of can't escape having a scar on the front of the knee, unfortunately, where you kneel. So it has been shown to have a higher incidence of kneeling pain. There are steps we can take to minimize that. We bone graft aggressively into those sites and really have a tight closure of peritoneum or the tendon to really make sure you have that fill in, and meticulous soft tissue handling usually minimizes that. But it is a risk, and it's always there, and it's kind of one of the downsides of having that graft. The quad graft is also, in theory, taken from a longitudinal incision.
Right.
As people have done more, they've gotten to smaller incisions. There are some folks that will make a transverse incision, kind of across the length of the leg, and then we'll harvest it through almost through a skin fold, and then we'll harvest it with a small harvesting instrument that can be passed up underneath the skin. You know, these can work. These can also truncate or shorten the graft. Sometimes you have to be tricky with it a little bit. I think people think that it's more cosmetically appealing sometimes, but it's also difficult to revise any sort of transverse incisions, or we tend to want things to be longitudinal, because then if you need to extend it, you can always extend it along the length of the knee through the same incision and not cross that incision and have issues. So, a quad graft you can also take with a bone plug. So you can have a bony fixation on one side. And I certainly, early on in my quad practice, use that a lot. And so I think it allows you to get bone fixation. The beauty of a patellar tendon graft is you have a tunnel that you create, a little socket in the bone. And then for a patellar tendon graft, you put the bony plug into that socket, and then you place what's called an interference screw, or a screw that fits in between the two. And it's about as solid as it gets at time zero. It's solid. The other thing is you have bone healing to bone, which we know reliably fractures heal in around 6 weeks or so. And so that thing is solid very early. When you take a soft tissue graft, either hamstring graft, quad graft, you're basically creating a tunnel in bone. You're putting a soft tissue graft or a soft graft, okay, into that tunnel, and getting the fixation. Sometimes you can use an interference screw, but sometimes it's harder because it's not hard. Oftentimes we use a button, and that's the way most quads are fixed now, is with a button way on the cortex, away from the joint, and that allows a little bit more play in the system, and usually a little bit more looseness. So, one of the issues is 2 millimeters difference side to side. That's the difference between a functioning ACL and a non-functioning ACL.
Yeah, 3 is the cutoff,
yeah,
right?
so you really, every little millimeter of difference, it all makes a difference. You also have healing. The bone heals into the graft as opposed to bone to bone, and it can be a little bit of a delayed healing process, and that's why many people are maybe preferable of having bone fixation. And really nothing has supplanted a patellar tendon yet. And a lot of people have a lot of opinions until they until they take care of one of those professional or D1 athletes, and then they say patellar tendon, right? So, and usually when you have a revision situation, most people would never challenge you and say, well, why didn't you use this graft, right? That's usually the one that is the gold standard. So usually for my high level athletes, that's kind of my go-to graft.
Yeah. Okay.
So guys like you, Dan, we can talk about allografts.
Yeah, allografts, right? Yeah,
right. That's what I want for my knee, right? Because again, allografts is a really good option.
Old guys like me, I'm giving up soccer. I'm going back to the stationary bike. I think
Fair enough.
So along the lines of this kind of emerging trend towards quad tendon graft, there's this debate now. Well, you can tell me which side of the fence you're on as far as the ALL, and whether that's a new ligament or whether that's an old ligament. It just and when that's injured, and the trend towards use of lateral extraarticular tenodesis to kind of control rotator stability. Tell me a little bit about your thoughts on that, about the emergence of that, and then also when you feel like that's indicated, whether you feel like it's.
Yeah, so it's been actually close to 15 years where they've kind of had this reemergence of the LET or the ALL. There's a discovery of the new ligament, this anterolateral, which is really a fold in the capsule. We've always been aware of it. It usually what pulls off the little piece of bone called the Sagan fracture. We've been aware of it for a while. But it became a little bit vogue to address it. So because not every ACL reconstruction is perfect, a lot of people are trying to continue to make it better, which is great. And the question comes up: is this the missing piece that's going to link it all together? So folks tried an ALL reconstruction with a different graft, with usually an allograft or an autograft. It was found to not be as anatomic or isometric when you bend it, and there were some concerns about stiffness. I did some ALL reconstructions probably in the early teens, decade. Did not like the experience at all, and went back to modified lateral extraarticular tenodesis. Right. This stuff's been around for a while. I'm lucky to have met Ron Losi a few years back, who's one of the early developers of extraarticular procedure before they had an intraarticular ACL reconstruction. We used to do this outside of the joint, extraarticular ligament reconstruction to stop the pivot shift or the pivoting of the trick knee. And my mentor John Fagan actually was able to teach me the LET during my time at West Point, and I've been using it since. And early on, I used it for the multiply revised patient. One of the joys of my practice is being referred 8-time revisions.
Yeah.
And like, oh my. So
you get the stuff no one else wants to touch at this point.
Right. I mean, I think that's you want to have a belt and suspenders. It's become very popular. Really, there's been the stability trial, which Al Getgood out of Canada and some others have participated in. This has been a great study that's been an RCT looking at hamstring plus or minus LET. And the findings were striking and how impactful an LET addition was with the hamstring autograft. And now that's the standard if you are a hamstring surgeon, because the impact of it is huge. There are randomized trials that look at LET with a patellar tendon graft and show difference. So I think, again, hamstrings, it's been clear for a while that they're probably an inferior graft when it comes to failure and return to sport.
Yeah.
And so people have been looking for ways to make it better for a while. We went through a phase where it was double bundle. That was going to be the answer. And then we had to augment it with PRP or stem cells, and now we have to wrap it in something. we have to, now we'll go to quad for everything. Now we'll add LET, right? And eventually it's going to be better than BTB. Nothing has really shown that it's better than patellar tendon.
Yeah.
Yeah. I mean,
I-
I'll stop there. I know you want to talk a little bit about internal brace too.
Yeah, I do. So I'm just curious again, like, I mean, it seems like the holy grail, right, has always been like something to kind of replicate that helical structure of the ACL, right, and trying to control that rotary stability. And that's what my question to you was that lateral articular tenodesis. Do you see, is there a worry about over constraining or kind of, altering the rotational kinematics, swinging the pendulum too far the other way?
Yes. And we will see that, like anything in surgery, right? We're going to see the downsides of these changes 20 years from now when everyone comes in with an arthritic lateral compartment. Right. So that's been the concern, and the biomechanical studies has shown over constraint in the lateral compartment contact pressures, right? And so I've not found it to be an issue with stiffness employing an LET.
Right.
I think when you look at a knee that is grossly unstable, we all know where that's going. And so for me, I accept that an LET may have some additional risk, but to me, it's less of an evil than having a grossly unstable knee with a failed ACL reconstruction, meniscal destruction, right? I mean, we all know where that knee is going.
Yeah.
And so I do some primary LETs very rarely. It usually has to be a unique situation with a patellar tendon graft. Yeah. I've had a couple of extremely hypermobile young kids, like extreme, like with 21 or 25 degrees of rock bottom hyperextension, and we've had other situations where they're mild meniscal deficiency or whatever the scenario is. It has to be kind of the unique situation. I've used it in isolation or revision situation. They have vertical graft that they're rotating around. You just add an LET to control the rotational stability. So there are some really cool opportunities. And yes, if I'm doing a hamstring autograft for some reason now on a young athlete, I would add an LET to it. But most folks don't find that you need that with a patellar tendon graft.
So. Okay. Well, since you hit on it a little bit already, why don't I dabble into, again, this, you mentioned the internal brace, right? We've seen a lot of success with that with UCL, Tommy John stuff.
Yes.
And you've seen now some people integrating the BioBrace into ACL surgery. Tell me, so for anybody that's not familiar, right, the BioBrace is like a biocomposite scaffold, right? It's this collagen matrix, right? But can you elaborate a little bit on that, and then your thoughts on using that and who you think it might be indicated?
Yeah, so I mean, I think that the internal brace is a proprietary name, right? That is an Arthrex product. That's basically a tape type suture with two usual anchors, one anchor on each end. BioBrace is also a commercial product sold by ConMed that they acquired that company a couple years ago, and they sell more of it actually bears load similar to a suture, but it's broader, and it does allow for integration of ligament tissue into it. There's a long history of synthetic products to replace grafts in the knee. The most famous, which was the LAD that really resulted in usual destruction of said product with diffuse synovitis in the knee joint. And there may be a role for some sort of suture product with a biologic solution. A lot of people have been adding this suture to graft constructs. They're usually soft tissue grafts, like we mentioned earlier. That's why it was kind of relevant earlier, because again, a lot of people, I'm always a hamstring surgeon. I've been doing this for 20 years, but I know the results aren't as good. So I'm going to add something to it, right? And so I'm going to add, and it's easier to add that to maybe a button construct than it is to a patellar tendon graft. The question that really comes in sometimes with it is, do I have to add another anchor? So I already got a tunnel and my graft, and then a screw, and then I'm going to add anchor to it to have it gets a little tricky.
Yeah.
Right? And so, and there's a huge cost for
The
some
Home
of these.
Depot knee.
Yeah,
right?
and it's a
That's
huge
right,
cost. Yeah. So that's one of the challenges that we face is it's a really large cost for some of these products without really the proven efficacy there. So yeah, but certainly for both of these, there's been a lot of work ongoing, and we'll continue to hear more about them. Certainly for the UCL, the anatomy is smaller, right? And so yes, it has changed the paradigm of reconstruction and moving it more towards a repair scenario, right? So, maybe it'd be fun to talk about these as it relates to a repair scenario on the knee, like a bear procedures.
So it's a good segue, right? Well done by you, right? I owe you a beer for that. So tell me, we are fortunate enough to be one of the Bear trial sites,
Yes.
Currently involved in Bear Moon. If you could, I'll defer to you on this. For anybody that's not familiar, BEARS is the acronym for Bridge Enhanced ACL Restoration. Tell us a little bit about what BEAR is and how this kind of became a thing, I guess, how this came in vogue.
Yeah, so I mean, Bear is Bear is a really amazing thing, and it's really one of the reasons I'm here. I was recruited here in 2014 to 15, and one of the big selling points is the ability to work with Braden Fleming. Murray, it was developed in collaboration with researchers here and in Boston Children's. So the early on, and I mentioned earlier John Fagan, one of the fathers of ACL surgery, initially discovered that the ACL was this torn ligament that was resulted in the trick knee, and opened up the knee and saw this thing torn before arthroscopy. And his solution back then early on was to do a repair or put stitches in it and repair it. And it worked okay. And the early results were showed that it worked well, but then the 5-year results had dropped off significantly. And so everyone abandoned ACL repair and went to reconstruction. That's been the standard ever since. And my colleague Martha Murray has devoted her career to this. Spent 25 years studying ACL failure from a biologic perspective and tried to develop a repair technique, and she has. So the basic science work was done there, and the collaboration with Braden Fleming here. I was lucky enough in 2015 to be able to do some of the bear surgeries in mini pigs here at Brown, and then we've been able to go on and get this bear procedure cleared by the FDA. And we were lucky to participate in Bear 2, which is one of the FDA trials here. And that's a cohort trial. So I've got patients that have received Bear that are now, I believe it's 6 years out now, because I started 20. Yeah, so 6 years out. I've got kids that have made it through high school, college, right, and are on their way. So it's really stood up to time, and it's now we've had a full commercial release, so there's a lot more of these being done. But we also really transitioned from that into this Bear Moon trial, which has been very promising. It had really done well in a randomized trial against hamstring, but it had not been tried against the gold standard patellar tendon graft. And so we applied for and received a very large NIH grant to perform a multi-center randomized controlled trial, and that is the Bear Moon trial. And so there are we've got multiple centers of really high volume centers and 13 extremely high volume ACL surgeons, and we're randomizing patients into either the Bear repair restoration versus a patellar tendon autograft. We've enrolled, I think we're close to 120 right now, across all the sites, and should be wrapping up soon. We've been very happy with the results. We haven't done a full analysis yet, but our patients are doing very well with it. Bear works, and I think until you see it, you're like, it seems
skeptical.
It's too good to be true.
Yeah.
Right? I mean, the advantage is you don't have to harvest the graft. Right? It intuitively makes sense to patients. Like, oh, I'm either gonna take a graft from somewhere else in your knee that's gonna hurt a lot, and I'm gonna
cause tissue damage.
Yeah, and I'm gonna drill across and get rid of your ligament, right? And so if I say no, I'm gonna take that ligament, I'm gonna put stitches across it, and then I'm gonna repair it. the challenge with repairs, you usually don't have enough tissue, and so you can't because it doesn't tear perfectly on one end, and so you end up kind of short sheeting yourself on that repair. And so basically the bear is a sponge that goes in and occupies the space and causes it, and is a bridge, literally a bridge to allow healing across it. And the rehab, certainly as you've experienced, is quite different, right?
For sure.
Yeah, we're relying on the biology. We don't put a big graft in a screw and feel solid.
Right.
It's you splint holding it in place until the biology takes over and it heals without tension.
Yeah,
And,
I mean, I think as Kurt Spindler put it, it's basically like Jello in there for the first few weeks, right? I mean, it's so yeah.
Most folks do, by the way, do well with the standards 2 weeks house free, right?
Yes.
And they do quite well with that, right? And so it is, and seeing them, they do really well, and they still, they have all their tendon grafts, and their patient reported outcome scores are usually off the charts better, and their return to sport we've seen has been very, very successful. So we're very happy with the bear results, and it hasn't taken over reconstruction, nor will it ever. There will always be patients for reconstruction because people come in a year later and then they don't have the biology present to be able to do a repair. But if the study, it's a non-inferiority trial, if it shows that it's as good as patellar tendon, it could change a lot of our practice.
So that's one of the things I was going to. I mean, you alluded to kind of the early returns of some of the research with respect to functional outcomes, return to sport. One of the other things they looked at was laxity, right? Yeah. So comparable to your autografts that way, as far as like laxity in the ligament, that kind of thing, long term.
Yes, and we've been very happy. We've been very happy with that. We don't have that data yet, but we're studying it with KTs going forward on this trial, and that's going to be very important, right? So I think because that's one of the concerns is can you get it as tight as it originally was? We talked all about even autografts like a hamstring graft that has just a little bit more laxity maybe than the other side. Whether that's the biology of healing or that's the fixation technique, it's hard to say exactly, but those are always the concerns.
With Bear, you mentioned a little already about people being outside of their window. Are there certain instances for our listeners, right? Are there certain who's a candidate? Does it depend on where the tear is along the ACL? Does it depend on other factors? Basically, for our listeners, who's a candidate for Bear? I'll let you.
Sure. So the early Bear experience was all with the proximal tears, meaning that they come off the femur. It never usually comes as a complete avulsion where it just cleanly comes off. It always leaves a little tissue behind. Majority of ACLs tears tend to be proximal or mid-substance. It's rarer to see a distal tear or a tear off the tibia. With the proximal tears off the femur, they have a longer stump that allows for a repair. And that makes it very appealing to be able to do a repair to one side with the other side being intact. So we tend to, early in our experience, we were very cautious, and these were all usually proximal tears with a little quality stump. But as we get more comfortable, we're getting more and more aggressive with them with mid-substance tears. They do very. It seems like a little bit of a stretch, but they've actually done very well with the mid-substance tears. So the timing is really important, right? Because at least we've been consistent with the FDA recommendations, which has been to do it with 50 days of injury. So sometimes that's a stretch for some patients because they don't know how badly they hurt their knee, and they see their primary, and then they get referred, and then they get an MRI, and it takes time, right? And so a lot of our athletes will see same day or next day. That's great. That's always the ideal, is seeing them fast as you can, and you have more time. But certainly a chronic situation, we have to rely on a reconstruction. There are some people doing bears out there beyond the recommended window. We don't know what those results are yet. We're not doing them as part of any trial, but I know from the company, they've shared with me that some people are going outside of the window. It'd be interesting to see how they do.
So on that note, what do you see? What are the downsides of Bear? What do you see? Again, we alluded to some of the rehab, the fragility of it in that initial stage. What do you see as far as where have some of these people been steered wrong, or what's the pitfall?
Well, I think the downside of Bear right now is that the level of experience in most surgeons is low.
Okay.
And so we've been lucky here as being kind of a beta site doing them. I've been doing these surgeries for close to 10 years, right? And so I did them in the lab in animals, I've been doing them now in humans. And so, and I'm part of a couple of trials before it was ever even released by the FDA. And so, I feel very comfortable with the Bear. There's a little bit of a learning curve. It's not hard. It's just it's for an an ACL surgeon can do it. It's just a lot of little technical steps. And so I think some people that are getting a Bear, there are Bears. Well, it's the first one done in Kentucky, or the first one done in this certain area, right? And so it's just it is always, I think, going to be a little bit of a learning curve on some procedures.
You never want to be the first as a patient, right?
Well, yeah. I mean, it's just it's experienced ACL surgeon can do it. It's not like it's different, right? Oh, sorry, it's not like the steps are a little different, but it's not like they don't do ACL surgery every day. Sure. But there are these little bit of learning curve challenges. We usually try to get the fixation as tight as we can all the time, and this is a little bit different. It's different for the therapists, right? That are used to moving them quicker. Yeah. We have to go slower. So those are concerns a little bit about Bear. It's also being done in an open fashion now. I think very quickly, at least we are still utilizing the FDA protocol as it's originally described. But I think very quickly it will move to an arthroscopic procedure, which I think would definitely minimize the morbidity and make it a lot more appealing for patients too.
So have you seen the evolution of the Bear post-op protocol as well? Like
yes,
the rehab stuff. I know that's changed within the last 1 to 2 years, right?
Yes.
The symposium summit. What have we seen on that front? I know initially, like I said, the tendency is probably to be a little more cautious with it because it is new, and then there you develop a certain comfort level with how much you can push, right? So do you mind touching on that a bit?
Yes, I think that we have been continuing to work on that is a little bit of a turnoff for some patients, the slowness of the early protocol, and there is concern about stiffness, etc. And patients want to be able to get back moving, but we have to do that in a safe fashion. So they have been able to the company has worked well on trying to roll out a more accelerated protocol, and we think that is safe as well. And so I think there's still more answers to come on the ideal protocol for it. I think the key is the key of like any of these is finding a quality surgeon, having a quality therapist that you trust and communicate well, and that's going to be the answer. Unfortunately, there's lots of options,
sure,
right? I mean, there's lots. I wish there weren't. I wish I didn't have to describe all the options because it can be overwhelming. I describe it as like the menu at the Cheesecake Factory, when you have 12 pages of things to look at. It'd be much better if you just went in and everyone got a cheeseburger, right? But it's not. There are some options, and it can be overwhelming for patients that come and we spend an hour talking about different graphs and Bear, and it can be a little confusing. The key is to find, a high volume surgeon that does a lot of these and that you feel comfortable with, right? And then have a high volume therapist that doesn't handle one ACL patient a year, right? That's what they do all the time, right? And those two things are going to be the patients don't always control all the technical aspects of it. They do control their surgeon that they select and their therapist they select, and that's where they should use that influence the most in picking someone that does a high volume.
Could not agree more. So we're running up on time a little bit here, so I don't want to cut you off because we could sit and talk ACL stuff all day. But I wanted to touch base with you and find out, just to kind of find out a little bit about the evolution of your thinking. Give us, for our listeners, because tell us one thing that you've evolved your thought process on, or your thinking in regards to ACL, or some revisions to your philosophy.
Certainly, my approach has evolved over time. I mean, I think I end up doing there's certainly a little bit of bias probably in this talk here, where we seem to really rely a lot on patellar tendon graft, and I think that's something that probably comes through. And I think when I teach my residents and fellows now, they think that that's always the way it's been for me. I actually did more hamstring graft in residency, and then in fellowship did almost exclusively hamstrings.
Oh wow.
Okay. Yeah. How about that? Right. And then I found myself in practice and just trying out what worked for me with my patients, and really fell in love with the patellar tendon graft. So it's not something that was dogma handed down to me from the high mountain where this is what you do, right? It's been my own experience. Yes, it's been my own experience, and little things have evolved over time. I'm lucky to have really trained in an era where we were beginning to do anteromedial portal, so I really don't do many transtibial approaches, which used to be the standard, right? And so I never really did that much in practice. But no, I've kept abreast of all of these changes. I think that the biggest thing probably in the ACL world is Bear right now. I think it's exciting to be part of the study that hopefully is going to have the answer as far as how impactful that is in ACL surgery.
Great. How about the opposite, right? How about one thing that still kind of vexes you or, frustrates you with regards to ACL surgery? Is there one thing you are still searching for the answer?
Yeah, I mean, I think one of the things that really frustrates me almost on a daily basis is I wish I could get to everyone quickly. I wish, that's always frustrating because I see people come in still, teenagers with destroyed knees. And I had one this week, tore his ACL a year ago and then did nothing about it. And then comes in and he had a bucket handle of lateral and medial meniscus, both sides. I had a gentleman yesterday who tore his ACL and flipped the bucket meniscus. Did the right thing, went to his primary care doc, right, who was mandated by insurance to what can you do before you get an MRI?
The PT, right? Yeah.
Weeks, right? Working on straightening out the knee that is locked, right?
Yeah.
And then finally gets the MRI, finally gets to me. And I was like, gosh, if I met you 6 weeks ago or 8 weeks ago, right, you would have had surgery within a couple of days. Sure. We would have popped that meniscus back in place, right? Hopefully before you tore it completely, right? And then reconstruct you all at the same time, right? And so the thing that bothers me, the things I can't control, right, before they get to me, right?
Sure.
And that part kind of gets me.
And we know that ACL in conjunction with meniscal pathology doesn't do as well long term, right?
Correct.
More susceptible.
Yeah, I mean, the meniscus is what drives the drain too. It really is. It drives the outcome. It tends to have a bigger impact than other aspects.
Okay. Well, so this has been great. I appreciate you again being our inaugural guest, and thanks for your time. Tell us, for some of our listeners here, anyone that's interested in kind of finding more out about you or your services, where can some of our listeners find you or contact you?
Yeah. So, we've got, it should be a robust description of things on the University Orthopedics website. I also have my own personal website, brettowensmd.com. I have a professional account on most social media outlets as well. And
you an active poster, or you just kind of have it there? And
I'm a little bit.
Gotcha.
I'm not as good as I probably should be.
Understood. Yeah, I think we can also.
I'm super excited to do this. This is a great. We love this community. I've loved being back here now for close to 10 years. I actually grew up in Rhode Island, so it's wonderful to practice in my home. It's great. So
you pronounce your R's too well. I would not have guessed that.
So. Yeah, no, I actually grew up in East Providence. Literally like a couple of miles from where I practice now. But I was out. I joined the Army at 18. I was gone and practiced for 11 years in the Army and a bunch of locations. And Yeah, so I probably added my R's at some point, and but no, I love being back here. It's a great area. We've got such a great. I mean, I love this practice. It's really a great group of people. You know, the surgeons are fantastic. The therapists are fantastic. The facility we have is great. It's really a great place to be. So
All right. Thanks again for your time. I appreciate it, especially delaying your start of your weekend here.
no, it's great to be here. Thank you so much for having me.
All right.